Prenatal Diagnosis Part 2, Invasive Genetic Testing and Carrier Screening, Module 3, Lecture 8, in the Genetic Series. Invasive diagnostic testing includes amniocentesis, which is done after 16 weeks gestation, and it has a detection rate of aneuploidy normal of 99.9%. Chorionic villi sampling can be done between 10 and 14 weeks gestation, and it has about a 99% detection rate. There is a risk of something called confined placental mosaicism, which is similar to the last module when we were talking about the non-invasive testing with the placenta. There's about a 1% difference between the placenta and the fetus, and that's because of trisomic rescue from aneuploidy. The risk of pregnancy loss to invasive procedures of amnio is about 1 in 500, chorionic villi sampling between 1 in 200 and 1 in 300, and both are at risk when looking at the sample of having maternal cell contamination. So in chorionic villi sampling, a piece of the placenta is taken. It can either go transvaginal or transabdominal, depending on where the placenta is. And again, the placental cells are analyzed. They're grown in a petri dish, and the chromosomes are looked at. And here we have a transabdominal chorionic villi sampling. Amniocentesis is done under ultrasound guidance, and a needle is placed into the amniotic sac. Skin cells from the baby slough off into this fluid, and that's actually what we're testing. We're actually testing ectoderm or skin cells from the fetus. So we're actually looking at fetal cells as opposed to CVS that we're looking at the placenta. So a diagnostic test can be done, as stated, by either amniocentesis or chorionic villi sample or CVS. We can look at chromosomes. We can do fluorescent in situ hybridization of fish for quick analysis for chromosomes 13, 18, 21 for a 24-hour analysis. We can do the more detailed chromosome microarray after this test. And we can also do single gene testing. So if there was a particular disorder that we were concerned about, we could do single gene disorders. Chromosome analysis. A karyotype takes about 2 weeks to get the results. The microarray can also further look for any kind of micro deletions as well as fish, which will allow us rapid analysis. In Illinois, pregnancy termination is legal until age 23 weeks, 6 days. After 23 weeks, it's considered a late-term termination, and there are only a couple places out of state that will do this for lethal abnormalities. It is important to confirm a diagnosis through CVS or amnio with any abnormal screen. The decision to terminate is often very complicated for the families, and that's why earlier and earlier detection of possible pregnancy problems, such as within the cell-free DNA, at 10 weeks, and then we can go on to the more invasive testing, allows us more time to help the family get through A, making the diagnosis, and B, helping them to make this decision so we're not up against this 23 weeks. The next thing we're going to discuss is carrier screening. It's ideal to determine if the parents are carriers of a particular disorder before the pregnancy. Because as with everything else, we're up against the gun with regards to making decisions. Cystic fibrosis, for instance, the risk varies with ethnic groups, but because it's common enough, population screening should occur. But there are a number of ethnic group carrier frequencies that we should consider. Individuals of African American descent, 1 in 10 are a carrier of sickle cell, 1 in 65 for cystic fibrosis, and beta thalassemia of 1 in 75. Individuals of Ashkenazi Jewish descent are at risk of a number of inherited disorders, 1 in 15 for Gaucher's, 1 in 25 for cystic fibrosis. Tay-Sachs, 1 in 30. Dysautonomia, which is a severe neurologic disorder, 1 in 32. And Canavan's, which is another severe storage disorder, 1 in 40. Individuals of Asian descent are at very high risk for alpha thalassemia at 1 in 20, beta thalassemia at 1 in 50, but cystic fibrosis is actually only 1 in 90 are carriers for cystic fibrosis. Europeans have a risk of cystic fibrosis equal to the Ashkenazi Jewish population of 1 in 25, and spinal muscular atrophy, which is a very severe neurologic disorder in newborns of 1 in 30. Hispanics, the risk of cystic fibrosis is down to 1 in 45, but the carrier risk for beta thalassemia is approximately 1 in 30. Individuals of Mediterranean descent, beta thalassemia 1 in 25, cystic fibrosis only slightly decreased from the Caucasian population at 1 in 29, and sickle cell at 1 in 40. So it's important to know an ethnic group because while individuals of African American descent are at significantly lower risk of carrying cystic fibrosis than the Caucasians, they're at higher risk of sickle cell anemia, and individuals of Asian descent are at higher risk of alpha thalassemia, but much lower risk of cystic fibrosis. So knowing what individuals are at risk of can help with carrier screening. There's more and more universal carrier screening that look at hundreds of disorders. For instance, in the case of Tay-Sachs, nowadays it's more likely for a baby to be born with Tay-Sachs that's not Jewish, because most individuals of Ashkenazi Jewish descent have carrier screening, so they would know if they were a carrier. And yet, even though the risk of Tay-Sachs in the non-Jewish population can sometimes be 1 in 50, 1 in 60, because those individuals sometimes are not carrier screened, they're the ones that end up with a baby. So Ashkenazi Jewish carrier screening, as stated, there's a high incidence of a number of different disorders. This is probably because of founder effect. Intermarriage within a relatively small community. For instance, historically, if there was a family in one small town in Poland that was of Jewish descent, their daughter didn't marry somebody in the town. She married somebody maybe 30, 40 miles away that was also Jewish. Any individual with at least one grandparent that's of Ashkenazi Jewish descent should consider Ashkenazi carrying frequent, testing. Currently, the panels include about 4 to 19 genes. 1 in 4 individuals with Ashkenazi Jewish descent carry one of these 19 Jewish disorders. Tay-Sachs is also more common in the French-Canadian population. Pan-ethnic expanded carrier testing. Testing technology has improved significantly, allowing us to look at over 100 disorders with a single test for a relatively small amount of money. Currently, there's no medical guidelines for this. However, in the practice of medicine, it's probably going to change rapidly. Preimplantation genetic diagnosis. So why would we do this carrier testing? To offer people options. So before they're pregnant, we have more options. One is they could get pregnant and we could do very early prenatal testing as early as 10 weeks with a CVS and look for, if there was a 1 in 4 chance of the family to carry a baby with Tay-Sachs or spinal muscular atrophy, we could diagnose that at a very early stage and allow, decisions to be made. The other option is pre-implantation genetic diagnosis. This requires in vitro fertilization in which the egg and sperm are combined in a petri dish, and at around the 16-cell stage, one of these cells is popped off here and genetic analysis is performed. If the embryo is normal, it's then implanted. However, if it's going to be affected with the disorder, it is not. Only unaffected embryos are implanted into the fallopian tube or uterus. This option, when parents are known to be carriers, helps us avoid an affected child. This can be for recessive, dominant, and X-linked disorders. Preimplantation genetic screening is also an option for ambulatory screening for embryos, and this is often offered in concert when we're looking for a single gene disorder, but also in older women that are having difficulty getting pregnant. And it can also be a problem with something like Huntington's disease, which is a dominant disorder. The difficulty with this is if one of the parents, how do you tell them that the fetus is affected without actually disclosing that the individual is affected? So, a couples of Asian descent, the disorder they might be at highest risk of being a carrier for is beta thalassemia, alpha thalassemia, sickle cell anemia, cystic fibrosis, or spinal muscular atrophy. And this concludes Module 3, Lecture 8 in the genetic code.